clinical trial, we did show significantly improved disease-free survival with the addition of pembrolizumab, but with that we did see more side effects than in the control arm that did not receive any systemic therapy. Fortunately, these side effects were generally resolved fairly quickly and were not long-term adverse events that have impacted long-term quality of life. And I think that one of the major benefits of this trial is that it places pembrolizumab as a potential alternative to chemotherapy, which is the more commonly used systemic therapy in institutions where these patients do receive systemic therapy in addition to surgery and radiation therapy. So when we look at this in the context of the adverse events in our trial compared to the adverse events in trials where people are getting combined chemotherapy, the adverse events are actually less significant and have less impact on quality of life. So I think that the bigger question moving forward is going to be decision making in terms of whether patients get any systemic therapy, whether the selection is pembrolizumab with some increased risk or chemotherapy with an alternative type of adverse events that has a greater impact on quality of life most likely than the pembrolizumab. So this clinical trial was stratified by tumor grade, and the majority of patients had grade 3 disease, and patients with grade 3 disease do have a higher risk of distant metastases. The improved disease-free survival that we saw in this trial was really driven by improvement in reduction in distant metastases, and given that grade 3 patients do have a higher risk of that, we're more likely to be able to see a benefit. Furthermore, the trial really was not powered in order to look at these subgroup analyses based on grade 2 and grade 3. So with the grade 2 population being much smaller, it's going to be harder to see an effect size, and we expect that if there is any benefit to those patients, it's likely going to be a smaller absolute benefit, just given that they have a lower risk of developing distant metastatic disease. So at this point, we see improved disease-free survival, and things are trending in favor of overall survival also being improved with the addition of pembrolizumab. However, our time point is relatively short. So the median follow-up at this time is about 3 years. And typically, in order to see a survival benefit from reduction in distant disease, it takes a bit more time. So we look forward to reanalyzing these data in 2 to 3 years when we have additional follow-up to see if those survival curves separate further and whether there is a statistically significant benefit in terms of overall survival. So this clinical trial specifically looked at 2 histologic subtypes of soft tissue sarcoma, specifically undifferentiated pleomorphic sarcoma and dedifferentiated or pleomorphic liposarcoma. So really these results should only be applied to those specific subtypes of sarcoma. Additionally, this trial was limited to patients with disease in the extremity or limb girdle, so this does not necessarily apply to patients who have sarcomas in other locations, such as the trunk or the head and neck. Additionally, this was limited to patients with stage 3 disease. So these are patients whose cancer measures greater than 5 centimeters and who do not have any evidence of distant metastatic disease. And then finally, it was limited to patients with grade 2 or grade 3 disease. So really at this point, these results should really only be applied to those specific histologic subtypes. So stage 3 undifferentiated pleomorphic sarcoma and pleomorphic or dedifferentiated liposarcoma. I think that the question of how to apply this for grade 2 versus grade 3 disease is a bit more challenging. As mentioned earlier, this was not powered for subgroup analyses based on grade. The greater benefit that we are seeing is in grade 3, but we really can't say at this point the benefit to grade 2. So I think that the greatest benefit will be in grade 3, and it'll be up to oncologists to weigh whether they think patients, for example, because they have very large tumors, even if it's grade 2, if they think that the risk of distant metastasis is sufficient to warrant the additional potential toxicity added by pembrolizumab.